And the right people and everything. So, specimen collection. So now we're talking about the sputum, because remember, the third thing was the sputum, whether the sputum culture is positive. So, you get the sputum culture before I start the drugs. Why? Because I don't want to have any drug skewing the results. Even though the drugs take a long time, and that's just generally for anything. I want to try and get as much as you can, get the specimens prior to starting the drugs. That doesn't mean you're going to have the results back, but you're just going to get the samples. So, early AM's preferred because, you slept all night, and hopefully all the bacteria down there, having a party, you can call them up. It should be on 3 different days. So you rinse the patient's rinsing their mouth first to get any bacteria from their mouth out of there, and coughing deeply from your chest. So you really want that mucus from your chest, not just spitting spit. So they might need to get an induced specimen or get it via bronchoscopy. So for that, we would need respiratory therapy does induce sputums, and bronchoscopy would be done in a lab. So for right now, we don't have to do all that. Because it is just like a little mini OR thing. Like for bronchoscopy, they need a consent, it has to be NPO beforehand. I should have asked that question. I didn't, sorry. Missed that opportunity. And then you can have extrapulmonary TB. So you can have TB that goes to the bone, you can have meningitis related to tuberculosis, can have it in your urine. So when people have that reactivated TB, typically you do get specimens from those other areas. Like, meaning if I came in with meningitis symptoms, like severe headache, change in mental status, I might have to get an LP, and then they check that for mycobacteria too. So whatever specimens would be needed that we get from the patient. So complications, so pleural effusion. So pleural effusion is different from pneumonia in that pneumonia, I can answer this question. Pneumonia means, Scott Clark, what's pathophysiology of pneumonia? Whether it's bacterial or viral. What happens with pneumonia? I won't look at you. See if you got nervous.
My brain's not working right now.
What's that?
My brain's not working right now.
I understand you, sir. Mine was working all day. I slept all day. Anybody? Any takers? Pneumonia.
Inflammation, fluid.
Well, yeah, inflammation of the. So I heard alveoli, so of the parenchyma of the tissue, beautiful, and yeah, it can be viral, can be bacterial, with some infectious agent. Could have aspiration pneumonia. And so that inflammation is of the lung tissue. And that little bit of that inflammation causes what? A little more fluid there, so gonna have those, period of auscultation, they're gonna have a fever, blah, blah, blah. With a pleural effusion, the effusion now is in the pleural space. So between my lung tissue and and my rib and my pleural cavity, fluid will collect.
Just in between the 2 layers of the lungs, right? Isn't that
Well, yeah, between the lung tissue itself and the pleura and the lining of my lung. Well, the lining of my chest cavity is a pleural space.
between the lungs too? The parietal and the visceral space.
Yeah, in the pleural space between the lung tissue itself and the
Cavity.
chest wall.
Okay.
Yeah.
So fluid collects there. Bad news. Yes, definitely can. So if somebody has a bad pleural effusion, it'll have to get drained out can do it like a little puncture, but a lot of times people need a chest tube to drain that out. So now with this one though, since we're talking about tuberculosis, it's usually pretty nasty. So pleural effusions, when there's serious when there's serous fluid, so serous fluid means what?
Intracellular, or,
Serous looks like,
I'm sorry, clear.
yeah, like straw colored, you know, not too nasty. Nasty enough, but not too nasty. People with TB can have empyema, as it's called, so it's thick, purulent drainage. Looks really milky, a lot of cellular debris in it. Right. But, and they really would need a high level suction to even get it out of there.
That's
E and, oh. I might be misspelling that. Can I fact check that and get back to you after the break? But yeah, it's called an empyema when the fluid's really thicker. Says bad news. And somebody with a pleural effusion, so they're gonna have our usual difficulty breathing, you know, dyspnea with exertion,
Pain.
pain. So can have a bronchopleural fistula. So fistula, going back to old 100, that means a fistula is caused by, a fistula itself means,
Tunnel.
yeah, so abnormal communication between two things. So bronchopleural means now I have an opening from my lung to my bronchus. It's not good, like an abnormal opening. So you can have that, and again, that's just because you have those big cavities of that dead tissue, so that's what can happen with those. All these can lead to respiratory failure, so respiratory failure is obviously, like, the end point is that I can't breathe, but that's gonna have a really, you know, high CO2, really low PaO2. And then extrapulmonary TB, so it means outside of my lung, I'm gonna have changes like lymphadenopathy, so that means what? Lymphadenopathy.
Lymph
Look at-
nodes.
Well, swelling to my lymph nodes. And with lymphadenopathy, generally they're tender, so tender, swollen. That's, hate to say it like this, but it's good when you have swollen tender lymph nodes, because that means infection. When you have non-tender lymph nodes, it's usually malignancy, cancer. But they could be anywhere throughout your body, this lymphadenopathy. So bone disease, so bone pain, really achy. And then, as we kind of already mentioned, could lead to kidney failure, because you can have tuberculosis of your kidney too.
Mm.
So that's where somebody would be getting urine specimens, you know, checking the UA to check for mycobacteria. So now on to medical management. So BCG vaccine, again, it's gonna be used more in those countries where TB is more prevalent, common for people who live in those countries to get it, and that's why, you know, you come here and they say, oh, I can't get it, so I got BCG. So I've never really known of anybody in the United States who's gotten this, but per your book and when I checked the CDC site, you definitely will be, this would be one to consult infectious disease about, because infants, children, and those two would be, if I was living in the house, again, is that person who's come from a different country and I'm living in the house with them, or somebody diagnosed with having TB, then they would get it here in the United States. And again, if I'm doing, you know, on a Native American reservation, if I'm working in a prison or some type of camp, like I think of the poor people, you know, probably those immigrant camps in Mexico, they might have TB if it, sadly. But one more time, the biggest point here, PPD is unreliable. They have to have the chest X-ray or the IGRA, quantiferon T-spot, to see whether they actually have TB once they've received the vaccine. And oddly, we'll talk about BCG vaccine, well, BCG itself next semester. I was just thinking about, when I looked at Ms. Alston, made me have a weird leap to Ms. Schrager, what she was talking about. It's a treatment for bladder cancer. We talked about that earlier. So now we're trusting the process. You already knew. Here it comes. Nursing questions. So for our assessment, so we already said things, you think of the populations who are at high risk. Have they had the BCG vaccine? Have they had any previous exposure? Are they a healthcare worker? What's their country of origin? Have they ever had a positive PPD test in the past or positive quantiferon? Then for their history of present illness, so that means though somebody presents what is going on right now. So I'm gonna ask them, like, they might not be taking their temperature at home, but have they had like chills at home, feeling hot and cold at home? Do they have a productive cough? And what would be really, even more worrisome if that sputum looked what?
Red or
Yeah, rust
streaky.
colored, bloody. What are their breath sounds like? 'Cause remember, we were worried about having crackles maybe. And their O2 sat. Or I'm sorry, what else could they tell us for the symptom review?
Difficulty breathing.
It could be difficulty breathing. Remember it was, night
Oh.
sweating at nighttime, weight loss, unexplained weight loss. It could be that sharp pleuritic chest pain, but definitely the weight loss, that's the things that they're gonna say to you. So subjective data they're gonna say to you is the weight loss and the night sweats, because we're not with them all the time. Usually, people generally don't say fever because you're not taking your temperature. But you're gonna say, I'm hot and cold, chills all the time. And then, so objective data, so things we're gonna observe, perhaps their clothes were ill-fitting. And then we're gonna, be doing their assessment to see, what their breath sounds are like, what their O2 sat is. So normal O2 sat's gonna be, normal range for that. Yeah, 95 to 100, that was an easy one. But things that can obscure that pulse ox are gonna be nail polish, it's a good one.
Poor
What else?
circulation.
Yeah, so if they're really cold, if they have perfusion issues, always a smoker. Those nicotine fingers. So, reviewing already, so active disease, initially it's gonna be what? It's kind of non-specific, remember, it's that weight loss, fatigue, night sweats. It's later when they get the hemoptysis, is blood-streaked sputum, medical, and could be rust colored. If they have a latent disease happening, are they gonna have symptoms? No, they're not gonna have symptoms until it gets reactivated. But they could have positive skin tests. And so just if somebody's HIV positive, because they are immunocompromised, sometimes they don't always have the classic symptoms. So that's why sometimes they go right to get a chest X-ray first. Because they think if my immune system's suppressed, I don't have enough troops to make myself have a fever and get the cough like that. Because sometimes that's why they don't always have the same symptoms, because my immune system is suppressed. And then, so results of, either the TB test or the quantiferon gold or T-spot. So I'm gonna read that TB skin test at what interval?
48 to 72 hours.
Yeah, 48 to 72 hours. And, oh shoot, this is another thing I printed upstairs. you actually, if somebody does mess it up, which I'm sure I've been guilty, no, I haven't, because I hate coming back to things. If somebody does mess up and not come back, get it read in time, you can actually just get it tested, you can just redo it, like, they don't have to wait an interval to have it redone.
But that's on, if it's powder, it hangs out forever. And you can see it
Right.
forever, it's not like it goes away.
I've never really, honestly, I haven't seen like, just in the old little test ones they have up to see. I've never really seen it on a real person. Have you seen it on a real person? Shut up. Get out. Are you from Angola?
Isn't that weird though?
Well, it's me, like me, this weird Schwann-Huron.
That's nice.
Oh, see? So maybe you have some different mycobacterium. And so the chest X-ray said about that was easy. So the sputum culture, so remember we said you have to get 3 different specimens, 3 days. So I'm not waiting until I get these positive specimens to put somebody in isolation. I'm gonna slide you right in isolation. If you come in talking about I've been losing weight and having a fever, man, in the room. This will be your last one. Perfect time. Oh, I'm sorry. So for the sputum culture, what it says it's gonna be positive for the acid-fast bacilli in the sputum culture. So that's really to diagnose it, you have to have the acid-fast bacilli of Mycobacterium tuberculosis in the sputum. But we're not waiting to get it. We're starting isolation before that. Our goal obviously is going to be what? Prevent spread of infection, treat the patient appropriately. Nothing testable in those goals, is what we've already said. But for airborne precautions, so the captain hit this on the head, so they're going to be on negative pressure room, private room, though you can cohort them, like if somebody else was ruling out for TB. I really never have been in a place that's that desperate. Generally, they are in a private room, but test question wise, it said that you could cohort them, but I've never known that to happen. So what PPP or PPE, I said PPP because I guess I have to go to the bathroom. PPE are we wearing, now we're gonna wear that N95 mask. So that's why you have to get the fit tested. And remember for that, just life-wise, changes in your weight, like you do have to, you could change your size of that mask over time. And then patient activity, so when are they leaving the room? Wait, essential things only. They're not going out for they certainly shouldn't be going out for a smoke anyway, but you're not going out for a smoke, no, you're not going to the cafeteria, you're not going to the gift shop, you're not going to your own lockdown, sorry. And then their visitors, when their visitors go in, they have to wear the mask too. Don't try and slip in there. But not really, we're pretty freaked out. But visitors are wearing the mask. And so it's gonna be a multi-drug regimen for at minimum 9 to 12 months. But it really, like I said, can even go longer than that, depending on the cultures throughout the treatment. Because we got obtained cultures to diagnose with TB, but throughout the course of drug treatment to see if they're not developing a drug resistant, don't have a drug resistance. They're gonna get cultures throughout the course of treatment. So this really could go up to 2 years. So long time. It's gonna be multi-drug. And then 712. Be back into place.